हेलो। हाँ ठीक है, चलेगा, कोई बात नहीं। हाँ ठीक। ठीक है तो 15 मिनट। सर ज्वाइन हो जाइए ना। हाँ।
नाही आता येऊन राहिलं इथे वागेसर दिसत आहे ना सर आ रही क्या आवाज
हाँ सर, आ रही है।
आ रही है ना
यस
और
सर।
ये शेयर स्क्रीन करके ना?
यस सर, शेयर स्क्रीन करके आप पीपीटी शेयर कर सकते हैं।
सर सबसे पहले गुड मॉर्निंग
पीपीटी ओपन कराओ
अमित सर,
आपकी आवाज
क्या मेरी
क्लियर नहीं आ
आवाज
रही
आ
सर
रही है? हाँ, आवाज आ रही सर अभी?
नहीं
यस सर।
मतलब आपकी आवाज अब आ रही है
अच्छा सुनिए, आपका पहले प्रेजेंटेशन खोल के उसको रिड्यूस कर लीजिए।
हाँ हाँ
आपका प्रेजेंटेशन ओपन कीजिए और उसको रिड्यूस कर दीजिए।
कर दिया सर
हाँ, अभी शेयर स्क्रीन का ऑप्शन दबाइए। हाँ ठीक है, उसके बाद कुछ विंडो खुलेगी, एक विंडो के लिए उसमें हाँ स्क्रीन शेयर करो करके। ठीक है,
एक मिनट सर सिस्टम प्रेफरेंसेस कुठे आहे रे बाबा सिस्टम प्रेफरेंसेस
एक स्क्रीन आया होगा सर शेयर करके, शेयर स्क्रीन करने के बाद। सर सर बहुत सिंपल है, अनम्यूट कीजिए, अनम्यूट कीजिए।
हाँ हाँ एप्पल से
हाँ
शेयर नहीं हो रहा है वो
हाँ, तो
एप्पल
मैं
से
बोल रहा
शेयर
हूँ।
नहीं हो रहा है
अच्छा, एप्पल का है कि आपका प्रॉब्लम आएगा? एप्पल एप्पल का
हाँ
फिर एक
एप्पल
काम
से
की।
शेयर नहीं हो रहा है
अच्छा ठीक है ठीक है, वो प्रेजेंटेशन ना हमको आप मुझे व्हाट्सएप पे भेज दीजिए।
हाँ अभी अभी करता हूँ सर ऐसा
हाँ अभी व्हाट्सएप पे भेज दीजिए, फिर हम इधर से शेयर कर देंगे।
ओके फाइल मैं मेल कर सकता हूँ ये व्हाट्सएप तो थोड़ा सा मुश्किल जाए
हाँ मेल कर डालो।
हाँ मेल करता हूँ सर एक सेकेंड ना
व्हाट्सएप पे भी हो जाता है वो, वैसे ही सेंड को सिलेक्ट करके
को मेल ओपन है
पीडीएफ करके, या मेल कर दो।
क्या लिखूं सर मेल एड्रेस
केयर निदान CARE
KARE हाँ
NIDAN NIDAN
NIDAN
केयर निदान
हाँ
CARE NIDAN केयर निदान @redipmail.com।
मेल सर भेज दिया देखते क्या एक बार
हाँ अभी देख दो।
नहीं हो रहा है जीमेल कोई एड्रेस है क्या सर
जीमेल भी है, ऐसे कि शर्विका SHAR
एस एक सेकेंड ना SHAR
VIKA
VIK
12
शार्विका 12
हाँ शर्विका 12 @gmail.com।
इंटरनेट कनेक्शन इन्स्टेबलच येत आहे थोडं. तिथे येतं का? तिथे बघ बरं. नाही ना, हा येत नाही ना. मेसेज साइज इज मोर देन 45.8. 45.8. सुने ना, मुकेश बंसर से बात कर ली.
सर आप लैपटॉप यूज कर रहे हैं कि मोबाइल यूज कर रहे हैं?
नहीं, मैं लैपटॉप कर रहा था सर.
हाँ तो लैपटॉप पे आसानी से हो जाए ना, वही से हो जाएगा शेयर स्क्रीन के ऑप्शन से ही। आपका लैपटॉप एप्पल का है क्या?
नहीं, वो एप्पल को ये एक्सेस नहीं दे रहा हूँ. हाँ, ये प्रॉब्लम जो है वो ये लैपटॉप एक्सेस नहीं दे रहा हूँ.
गुप्ता सर को भी वही प्रॉब्लम गया था।
हो ना. ज्यादा MB का भी है, इसलिए जा नहीं रहा है वो.
मेरे ख्याल से वो व्हाट्सएप पे हो जाएगा वो।
और व्हाट्सएप पे गूगल में एक मिनट सर. तो याच्यात जाऊ. सरांची लिंक टाकावं. हे वेब व्हॉट्सअप चालू आहे. आता व्हॉट्सअप आहे ना. काय काय डिवाइस लिंक डिवाइस लिंक डिवाइस लिंक डिवाइस. पण हा वेगळा ऍड्रेस आणि तो वेगळा ऍड्रेस होऊन जाईल. ऍड्रेस आणि तो वेगळा ऍड्रेस होऊन जाईल. काय करतो कुठल्या तिकडच्या का इकडच्या. घेऊन जाऊ ना. आला ना. आता सरांचं नाव टाकावं लागेल. हा, आता याच्यामध्ये काय करू. हे असं आता हे जाईल ना सरांना. नाही, आता हे सरांना जाईल ना. 32 MB हो जास्त आहे म्हणतो ना तो. त्याच्यापेक्षा फास्ट जाऊ नाही शकत ना. ठीक आहे ना, जाऊ दे. चाललाय तर जाऊ दे ना, अजून सरांना त्रास.
हाँ हाँ, ये आया नहीं इसलिए बोला थोड़ा। Good morning, everyone. I beg pardon to everyone for starting the webinar late. The file is being getting converted into the PDF format, and as soon as it will be done, we will start it again.
इथूनच बोलतो मी. इथून ऐक ना दीपक.
Good afternoon and warm welcome to one and all gather over here to attend today's webinar. I, Dr. Sachin Borkar, Associate Professor in Rog Nidhan Department, and I feel privileged to host for today's webinar, a national webinar, Arbuda Prabodhanam 2022, organized by Jupiter Ayurved Medical College in association with Rog Nidhan and Vikruti Vidyan Postgraduate Association and Rog Nidhan Department, Jupiter Ayurved Medical College. We are happy to tell you that today's webinar is approved by Maharashtra University of Health Science Nashik, and this is a 26th webinar arranged by our college. Today, it is a great honor for all of us that we have a distinguished guest speaker, Dr. Amit Jaiswal sir, oncosurgeon from Care Hospital, a renowned hospital from Central India. We have another speaker for today's session, and that is our own dynamic principal, Dr. Subhas Wage sir. We are also have Dr. Sampat Bhatane sir with us. He is a principal of B.R. Harne Ayurved Medical College, Thane, Mumbai, as a Maharashtra University of Health Science Observer for today's webinar. Our chief patron, Mrs. Tarini Nikhare madam, and Dr. Santosh Sawan sir, Secretary, Rog Nidan Vikruti Vigyan Postgraduate Association, and Dr. Aishwarya Ranade madam, Vice President of Rog Nidan and Vikruti Vigyan Postgraduate Association with us. Again, I welcome all the respected dignitaries for giving your valuable time. Now, we are going to start our first session. For that, I would like to introduce our guest speaker, Dr. Amit Jaiswal sir, who is going to deliver his lecture on topic Trends in the Management of Breast Cancer. Dr. Amit Kumar Subhas Jaiswal sir has done his graduation from GS Medical College and KEM Hospital, Mumbai. He has completed his post-graduation MS in General Surgery from Lokmanya Tilak Medical College, Mumbai. Also completed super specialty training in surgical oncology from Tata Memorial Hospital, Mumbai. Currently, he is working as a consultant oncosurgeon at Care Group of Hospitals, Nagpur. I welcome Amit Kumar sir and request you sir to please proceed further. Over to you, sir.
Good morning, everybody. I'm really sorry for the trouble. I was not able to upload my presentation and share screen, which was prepared on Keynote. Some things which are not in our hands. At the outset, I would like to thank Wage sir for asking me to present on this topic to the August gathering, which is there online, starting from the chief patron, Mrs. Nikhare madam, the secretary, Dr. Chauhan sir, Wage sir, principal, and the MUHS observer sir, Dr. Sampat sir, and the organizing committee team that led by Dr. Borkar and Dr. Hadole sir. My relations with Dr. Wage sir go long back, since say 2008-9, and it's been honor to reconnect with him after so long time, because once he left into his practice and then joined Jupiter, we met. We have been meeting very far and few, and we are just in touch on phone. So it's my pleasure to meet him again once before this meeting, and thank him to allow me to deliver a lecture on this topic. Now, coming back to this topic, what has changed in breast cancer in last, say, around 3 decades? We'll be just going through it in the most simplest form which we can think about. And I would be talking in between Hindi and Marathi so that everybody can understand it. And you can write your questions with you, and we'll be able to answer it once the lecture is finished. So if Dr. Borkar sir says okay, then we can start the lecture, sir.
Yes, sir. You can proceed.
I mean, this is how a patient would react to you. Please, I mean, I'm very sorry that we'll be seeing this in PDF format. So the animations and everything will not be able, I will not be able to show it properly, but I would try to talk more rather than show it on slides. So this is how a patient reacts and relatives react when you see a patient in an outpatient department, or right now if somebody sends you a WhatsApp that his or his relative or her relatives have been diagnosed with cancer, because the cancer word which starts with C is full of fear. Because, next slide please. Can you scroll it down? Next slide. Yeah, please. Now, the cancer word is really fearful for patient and relatives because the first thing which comes into his or her mind is that the end result, that my end is near, that cancer is going to take away my life, and that fear that my end is near gives you the reaction which we saw in the previous slide. Next slide, please. But nowadays, what has happened over a period of time in last 2 or 3 decades, we have been able to counter this menace of cancer with the help of three main tools, which we can call as weapons of cancer destruction. The first tool, which is very ancient, which even Susruta has mentioned in his ancient textbooks, is surgery. The second thing which came into vogue is chemotherapy. That is, in simple words, the injections and the tablets which we give to decrease or take care of cancer cells. And number three is radiotherapy. Radiotherapy is the radiation which we use to counter the cancer menace. Now, all these three are the basic modalities with which we counter or take care of cancer. Now, modifications have happened in these three techniques, and the best example of modifications or what we call as innovations have happened in breast cancer treatment. One of the simplest cancers which are being treated by these innovations, and only problem with breast cancer is that the treatment is long in most of the cases. Next slide, please. Now, in any cancer treatment, as you can see that one surgical oncologist is involved, medical oncologist is involved, a radiation oncologist is involved. All these three people are involved, but behind the scene, there are a lot of people who are involved who do very small actions to take care of these patients. But these small actions by lot of people bring about big change in the outcome and decrease the morbidity and decrease the chances of mortality of these patients. Now, who are they? I would like to tell the august audience that the most important person who will help three of us, that is medical, surgical, and radiation oncology as a team, is the dietitian. The dietitian is a person who, जिसको अपन बोलते हैं पर्दे के पीछे के लोग. These are the people who give them, because most of the patients of cancer will have problems with regards to swallowing, with regards to appetite. During chemotherapy, during radiation, they will have problems of mucositis, whether it is cancer rectum, whether it is oral cancer, whether it is breast cancer. All these will have side effects in such a way that they will not be able to eat properly or proper diet. So what dietitian does, they give small tips to these patients so that the caloric intake is maintained, number one, and number two, they get adequate amount of proteins, so, which are most important building blocks to improve the or take care of the side effects which a chemotherapy will cause, or which radiation will cause, or even surgery will lead to. So all these actions which are done behind the scene by dietitian are really helpful in bringing out a good outcome in our patients. Any patients, be it breast cancer, head neck cancer, esophageal cancer. Similarly, another person which is of very much or very important help to us as clinicians is physiotherapist. In breast cancer, as a dictum, after surgery, day one after the surgery is done, post-op day one, the physiotherapist goes in their room or in their wards and does proper exercises so that the shoulder doesn't get frozen. So all this help in long run. Now, if I do a good surgery, but I don't do a good physiotherapy or do not take care of that diet properly, which he or her, patient should take, the outcome is not that good. Now, if the patient is not doing proper physiotherapy, the patient will have a good surgery, good chemotherapy, good radiation. But ultimately, what will happen? She will be left with a frozen shoulder, which is more traumatic for her because she has got cure from cancer. She's a cancer survivor, but her shoulder gets frozen. So there are many people who are behind the scenes, who are not, who are basically the unsung heroes, which we can call, who help us at different stages of management of these patients and ultimately bring about a big change in the outcome. And ultimately the laurels are to the clinicians that I have been operated by this and so person, or given chemotherapy by so and so person, or operated or treated at this hospital. But the people who are behind this, that is dietitian, physiotherapies, good nursing care, are the ones which lead to good outcome. Now, why are we talking today of breast cancer? Because it is the leading cause of death among women. And overall, according to Indian Cancer Registry, 9% of all cancers are right now breast cancer. So roughly around 80,000 of the cases which are mapped by the Indian Cancer Registry are basically breast cancer. Next slide, please. However, it is gross underreporting which is there. In India, cancer is a basically global disease, and India is not far behind. In 2016, we saw around 14.5 lakh new cases. In 2020, it is about 17.3 lakh new cases, and 9% of approximately of them are breast cancer. The 80,000 number which we saw was around 2011. But if you see over a period of time, the number of registering has improved. The people who take the numbers, who collect the incidence and prevalences from different hospitals, the numbers have improved. But still it is gross underreporting because diagnosed cancers in small nursing homes, small villages, small cities are not mapped. But important thing to note is if I am saying that it was 80,000 in 2011, which we were talking, and it was about 9%. If you extrapolate it today in 2020, we don't have results in 2021 at present with us. But if you still consider 9% of 17.3 lakh cases, it will be approximately 1.5 lakh new breast cancer cases every day around India, which have been reported or which have been registered by Indian Cancer Registry. So it is a big burden right now in India. Next slide, please. Another important thing to note is that if you compare it worldwide, the incidence in India is still approximately 50 to 60% of America, around 75 to 80% of China, the diagnosed cases, and deaths. If you compare, even if the numbers are more in United States of America and China, the number of deaths, if you see in that red column, is the number is pretty high in India. What I mean to say that even if the numbers are low as compared to say America and China, registered numbers I'm talking, the deaths are quite a bit more than what Chinese and United States of America report. Next slide, please. So grossly, if you see, every sixth case in America dies. That is 1 out of 6 patients who have been diagnosed as breast cancer die in America. Every 4th patient dies in China, and every 2nd patient dies in India. If you remember the numbers in previous slide, after every 145 new diagnosed cases, 70 people die in India. That is, every 2nd patient will lose because of breast cancer. Next slide, please. Now, most important factor which leads to such high mortality in India is the numbers are increasing. There's no doubt about it. There is lack of awareness and screening in high risk population. And most important factor which decreases long-term survival is late presentation at diagnosis. Next slide, please. This is our hospital data. This is care hospital data for about 12 years. You can see that 52% of cases, these are operable breast cancer. I have excluded stage 4 disease because that is something which we should not discuss as a medical fraternity, because if you are diagnosing in stage 4, it is failure on our part that we have not been able to diagnose them in stage when it is curable. So in curable cases, more than 50% of the cases we see in stage 3 disease. About 43% are stage 2, and less than 5% patients are diagnosed in stage 1. Now these stage 1 numbers are exactly reverse in America and China, because they have something called as screening mammography for all of their people. Next slide. Now, what are the causes of rapid increase in breast cancer numbers in India? The increased incidence of urbanization, the rapid urbanization which is happening around India, across all the states, has led to increased incidence of breast cancer. In fact, the numbers are suggestive that it has taken as number one or leading cause of cancer in India. Till now, cervical cancer was the leading cause of cancer in India. But if you divide India into urban India and rural India, you will come to know that in urban India, breast cancer has overtaken cervical cancer as the leading cause of cancer in India. Now, this has been proven properly by analysis which has been published by Nagarani and et al. In Indian Journal of Cancer in 2014, that if a lady stays first 20 years of life in rural area, it decreases the risk of her having cancer. So that means that lifestyle prevalent right now in rural area of India is protective against risk of developing breast cancer. So if you stay in rural area or practice lifestyle as if you are in rural area, then it is indirectly protective against you having or developing a breast cancer. Next slide, please. So let us come to our Nagpur. Breast cancer is the leading cause of cancer. We are leading in. Breast cancer is the most common cancer in Nagpur. About 32% of registered cases are in breast cancer. Next slide, please. And the most common causes of breast cancer are early menarche, late menopause, obesity, late first child, Western style of diet, OC pills, and no breastfeeding. Now let us come to it one by one. If you see the first two causes, early menarche and late menopause, these are something which are unavoidable. These are something which is determined by your genes. These are hereditary. If a mother has early menarche, most of the girls will have, or her daughters will have early menarche. If she has late menopause, most of the time her daughter will have late menopause. So first two are unavoidable risk factors, unavoidable causes which are not in the hands of a lady. But if you go from the apart from these two causes, rest all are in the hands of the ladies. Obesity, sedentary lifestyle, not exercising leads to obesity. Western style of diet is something which leads to obesity. It has been proven by different trials. Another important factor which has led to increase in breast cancer is career. Therefore, late marriages leading to late first child, using OC pills to delay the first child. And even if you have child, not breastfeeding because of careers, or not breastfeeding adequately because of the career. So all these 4 or 5 factors These are something which are avoidable. Now, Government of India is doing on its part what can be done, like by increasing the leaves for ladies who are pregnant to about 6 months. But people using it adequately and using it for herself and her child will benefit from it. But somebody who doesn't want to breastfeed, who wants to go back to her career fast, it becomes difficult for any government to impose restriction on that. So these 4 or 5 things, if they take care of, then the chances of having breast cancer decreases. Next slide, please. Now, any disease you have to come to a diagnosis. Anybody who walks into your OPD with a breast lump, what you will do a basic 3 tests to come to a conclusion. One is a clinical examination. You need to do thorough examination of the breast and the axilla. And second important thing is that once you feel that there is something suspicious, then you will go ahead and do a basic test like mammography. Now, nowadays, mammography is always associated with an ultrasound. So it is termed now as mammosonography, because the sensitivity of mammography alone or sonography alone is less as compared to if you use both of them. So the chances of your diagnosis, the sensitivity increases if you use them both at the same time. And the pathological test, which you will order after your radiologist and your clinical examination infers that there is a high chance of cancer. So then you will go ahead with the pathological test. Next slide, please. So in clinical examinations, what you do, you will ask for signs and symptoms. That patient may come to you with a lump in the breast or in the axilla. She may come to you with nipple discharge. And in some cases, she may come to you late in stage 4 disease with some symptoms related to, say, bone, brain, lung, or liver metastatic disease. Now, at the outset, I would like to tell you that the 98% of the breast lumps are not cancers. What I mean by that is every lady will have small lump here and there, and that doesn't mean that it is breast cancer. So what I mean by that is that every patient of breast cancer lump should not be thought of as cancer, and should be ideally thoroughly examined, investigated by doing a mammography, and if there is a high suspicion, then only you should do a FNAC or biopsy. So at the outset, you should calm the patient that 98% are not cancer, but for 2% we should do a mammo sonography, and then we'll decide if anything else is to be done. Now, with regards to nipple discharge, every lady will have small discharge here and there. A whitish or a slightly milky discharge are not something which you should be worried about. However, if there is a red discharge, red nipple discharge, or in practical terms, what we say as if it is a bloody nipple discharge, then it should be investigated. Now, what should you do if there is a bloody nipple discharge? We'll come to that later. If you have axillary nodes, then you should not ignore it. You should FNA it. If you have axillary nodes in addition to breast lump. And if you have metastatic disease, then you have to find out whether it is from the breast or not. And if it is there, then you should do FNAC or biopsy of that area. So take home from this slide is that first at the outset, you should try to reassure the patient that only 2% of all the breast lump we see in outpatient department are cancer. The number of the percentage of patients in whom the cancer prevalence increases is in the older age. So younger patients should be who are more anxious should be reassured that it is not that every lump is cancer. Any patient with bloody nipple discharge should not be left alone. We should do a nipple discharge cytology. And in that cytology, we may find two findings. One is proper cancer cells or some things which are leading to bleeding in that duct. Now, that can be papillary lesion, which needs to be taken out. Or in patients who are having axillary nodes in addition, you should do an FNSE of both lump as well as axillary nodes. Next slide, please. So if you see what I've talked till now will hold is holding true for last 100 years. In our books, it has been mentioned for last so many years, triple assessment is gold standard for breast cancer. Now, what is triple assessment? Number one, the clinical examination which you have done in your outpatient department to know the exact extent of primary cancer in the breast and the axillary nodes. Number two, pathological confirmation of this by doing an FNSE, a biopsy, or an incision biopsy or an excision biopsy. Number three, bilateral mammogram, which was mentioned before. You just add sonography to this. So it is mammosonography. And we are now adding a fourth step, because in all the patients before, it used to be surgery followed by all other treatment. Now, since in some patients we give chemotherapy before surgery, which we call as neoadjuvant chemotherapy, what we do nowadays that we do a ER-PR HER2 receptor study if the neoadjuvant chemotherapy is planned. Now, what I mean by that, I'll just come to it up in some later slides. Next slide, please. Most important thing which you should tell to your patient and relative is early detection is the best protection in breast cancer. Next slide, please. And for that, you should teach patients' relatives, those who have been diagnosed with breast cancer, breast self-examination. What I mean by that is, any patient of yours who has got breast cancer, you will treat them. You will treat them with surgery, chemotherapy, radiation, hormonal treatment, and all that stuff. But most important thing is to teach patients' relatives, that is patient's real sister, patient's daughter, breast self-examination, because these people who are first degree relatives of patient become high risk for breast cancer as compared to other people in the population. And we should give them basic tips that it should be done monthly. The breast self-examination best time is 7 to 10 days after first day of period. You should ensure that the breast self-examination should be done on the same day of every month, even if she is not menstruating properly. And it should be taught to every patient's relatives, first degree relatives, after 20 years of age. Next slide. And what should the people see while doing patient breast self-examination? The most common thing which we see in breast cancer is lump, which is in breast, and most common is painless unless skin is involved or ulcerated. In few patients you see discharge or bleeding through nipple. In few patients you can see, especially who have big breasts, that the breast size or contour has changed. In some cases the nipple has got inverted. In some cases you see that the breast is bang normal, but the nipple areola complex color or appearance has changed. And in very few cases where you have inflammatory breast cancer, you see no lump is palpable. However, there is redness or pitting of skin over the breast, just like skin of orange. Therefore, you use a word pudy orange to describe this. I think we should forget about this because this is a very rare cancer. Most important thing is lump or thickening in the breast, which are often painless. Pain hot navta म्हणून मी डॉक्टरांकडे नाही आले. This is the most common history which we see in OPD. Discharge or bloody nipple discharge or bleeding from the nipple. Change in the size of the breast, especially in large breast, and retraction or inversion of the nipple. And in few cases where we label it as Paget's disease of the nipple, we can see change in color or appearance of the nipple. The color of the nipple as well as the surrounding areola may change, and which should alert you to do a biopsy of that area. Next slide, please. Another important thing when we sit in the OPD and do an examination is we should not palpate with 2 fingers. Generally, when we do examination, we palpate the breast as if you are palpating it with 2 fingers. If you palpate between 2 fingers, you will feel lumps all over the breast. If you palpate it like this, ideally you should palpate with flat of these 3 fingers: forefinger, middle finger, and ring finger. The pads of these fingers should be used to feel the texture of the breast and not pinch it in between the 2 tips of fingers, between thumb and first, second, third finger. So the basic dictum is to palpate it with the pads of fingers against the chest wall like this and not like this. Next slide, please. And how do you palpate it? You can palpate it from upside down, or you can palpate it in this pattern, which is whirling pattern, or you can palpate nipple first and go to 12 o'clock position, nipple first, 1 o'clock, 3 o'clock, 5 o'clock, 6 o'clock, in this way. So whichever method is okay with you, you can palpate it. Only thing is always palpate with the pads of the finger. If you palpate it with the in between the fingers, then you'll always feel that the whole of the breast has got the lumps. So always palpate it with the tips of the finger. Next slide, please. You can teach them the breast self-examination. These are available on Google. I'll just skip through. This is something which a lady should do. She should look at the mirror, undress up to the just below the nipple, and see how the shape and size of the nipple is. See the color of the breast is. See the color of the nipple areola complex. It should be even on both the sides. Next slide, please. Then she should see the breast and nipple areola complex after raising her arm and look for the same changes which she saw with her arms by side. Next slide. Next slide, sir. Now, while in the mirror, while she is moving her arms from side to above the head, look if there are any signs of bloody discharge from both the nipples also. In addition, because once she moves her hand up and down, sometimes the fluid oozes out from the nipple. Next slide. Same things can be done while lying down, and in addition to inspection, she can palpate it. Again, teach her to use it, use the pads of the finger rather than pinching it. Next slide. This can be done in circular motion or in different motions, which I have shown you in previous figure, that is palpating the nipple first and going towards the lateral or outer edge of the breast. In addition to that, she can be taught how to palpate the axilla also. Next slide. Everything is available on Google. People can just go through it. Same thing can be covered by palpating in standing position also. Next slide. Most important thing as a clinician is to do breast examination always in lying down position. All breast examinations should be done in lying down position. If you try to palpate in sitting position, you may miss some lumps because breast falls in front. So a lump which is deep seated may not be palpable if you do a examination in sitting position. And to the contrary, when you are doing an axillary examination, it should be done in sitting position. So if I'm going to palpate the axilla, left axilla of the patient, I should palpate with hand on my hand, her left hand on my right hand, and palpate with my right fingers or fingers of right hand. And if I'm palpating her right axilla, then I should palpate it with fingers of my left hand. Next slide, please. When should the clinical breast examination start? In patients with high risk, that is patient who have got his mother or her mother's sister, real sister, or sister having breast cancer, The clinical breast examination should be done from 20 years of the age for the near and dear relatives. It should be done by anybody. I mean, it can be done by a general practitioner, a gynecologist, a surgeon, or maybe a cancer specialist. Anybody can do it, and preferably from the age of 20 to 39, high-risk patients should do a clinical breast examination every 3 yearly, and they should practice self-breast examination at their home every month. Anybody who has completed her age of 40 years can do a clinical breast examination with or can keep on doing self-breast examination and should undergo clinical breast examination by clinician every year. Next slide, please. Now, coming to once we have diagnosed it that it is a breast cancer, then for our convenience, we have divided into, say, 4 different groups. The first one is operable breast cancer. The fourth one is metastatic breast cancer. These are absolutely clear. First one is a small breast cancer, which is operable. And fourth one is metastatic breast cancer. That is something which has started from breast and spread to different parts of the body. Now there is a second and third group. Second one is large operable breast cancer. Now these are small group of patients in whom the breast size is big and the size of tumor is also big. But since they are the lump is in bigger breast, we can still treat as if it is an operable breast cancer. Number third is locally advanced breast cancer. These are small group of patients in whom skin is involved, nipple area is involved. You have a lot of nodes which are discrete or matted, and these patients have to be treated differently. The first group of patient, that is operable breast cancer, the treatment starts with surgery. The fourth group of patient directly go for chemotherapy or radiation in addition to that. Now in second and third, the third group of patient, that is locally advanced breast cancer, generally these people are given chemotherapy, they are downstage, and then they are treated with surgery. Second group is very a small group of patient in whom you have to use your acumen clinically, whether you should offer her surgery first or you do give chemotherapy, decrease the size of the breast lump, and then operate. Next slide. Now, who are these operable breast cancers? Any lesion which is less than 5 centimeter with maybe 1 or 2 nodes here and there in the axilla and non-metastatic are operable group of patients. And as I said, any lesion is more than 5 centimeter with no skin involvement. I mean, they don't have any locally advanced signs. And maybe here and there some node. And if they are non-metastatic, these are large operable breast cancers. Next slide, please. So what you do once you have reached to a diagnosis of breast cancer, what additional investigations which some people may require? As I said, from radiological point of view, if somebody has diagnosed breast cancer in his or her local town where mammography is not available, then you can do a mammography. In some patients where those patients who want breast conservation surgery, you may require an MRI breast. The metastatic workup is done in 2 manners. The most common metastatic workup, which has got best evidence, is CT chest and abdomen, and second is bone scan. Now, in last, say, 5 years or so, people are doing PET scan as full body scan, because most of the patients say कि हमको PET करना है. Sir, PET करून घेऊया. This is the reaction which you see in your OPD. So although CT chest, abdomen and bone scan is equally effective in diagnosing metastatic breast cancer, but you tend to do so because of patient's pressure. Even though it is not the first thing, therefore I am not mentioned here PET scan at all, because there is a class 2A evidence. So it is not class 1 evidence that you should do a PET scan for every patient of breast cancer who is operable. In some patients in whom you suspect that there is some signs and symptoms that sometimes brain is involved, you may do a MRI brain once in a while. Maybe if I see, say, 100 patients, I would be doing MRI brain in maybe 1 or may not be doing in even 100 patients. But if you suspect there is something wrong in the brain, then maybe you will do an MRI brain for those patients. Next slide, please. Now, this is a photograph to demonstrate how a mammography is done. Mammography is done in two positions. It's craniocaudal as well as mediolateral. There are two views which are taken, and then you do an ultrasound. And those two photographs, which are digitally enhanced and then sent to you. Next slide. When should you do a mammogram? For any lady who has got a family history of breast cancer, she should start doing it once or twice a year after the age of the 40. Always in patients in India, if she crosses the age of 50, you should ideally advise them to do every year mammosonography. Now, less than 49 with family history of breast cancer, there are some people who are not very keen on doing mammography. Then in those patients, at least you should all our healthcare providers should tell them about the risk and at least make them aware of self-breast examination. And after the age of 50, ideally they should undergo regular mammography. Next slide. So coming to pathology, how pathologists help us? The most common test which we do in our outpatient department is our FNAC of breast lump. And about 90% of our patients are treated on FNAC. However, in a small group of patients, 10%, these are operable patients, the first group of patients who are having less than 5 centimeter disease with hardly any node here and there. Now, in some patients, FNAC is inconclusive, where their patient pathologist will say clinically, correlate clinically, I am not sure. In those patients, you can do a true cut biopsy. True cut biopsy can be done in outpatient with the help of gun, or you can do an incision biopsy. And in some patients where you are not sure, where the pathologist is not sure, but there is a high index of suspicion, आपको लग रहा है कि नहीं ये normal नहीं है, then you should advise them an excision biopsy. All these three things, the pathologist will be absolutely clear. Tell us at the end of these either of these three procedures, and then we can take after that what is to be done. Next slide. Now let us come to the most important factor which gives patients her life is surgery. If you see, if the 80% of her life is because of surgery. And what are the basic principles of surgical resection? These principles of surgical resections have remained the same over decades, over centuries. Most important is adequate margin of resection. Now, adequate margin of resection is because cancer is not round, it is not oval, it is not regular like square. It is just like amoeba. You will have small troughs and heights and troughs and heights. So because of that, what you intend to do is you intend to remove a normal sliver of tissue, breast tissue around that lump. Second most important factor is there should be no spillage. You should not violate the tumor. You should not puncture the tumor. Number 3 is in today's world reconstruction. And number 4 is minimal manipulation. In all these 4 factors will ultimately give her the 5th principle of surgical resection is good cosmesis at the end of the surgery. Next slide. The first person to treat breast cancer surgically was Halsted. Now, breast cancer treatment has evolved like anything over a period of century. It started with removing the whole of breast, nipple areola complex, underlying pectoralis major minor muscles, and removing all the group of axillary nodes along with the supraclavicular nodes and internal mammary nodes. This is called as ultra radical mastectomy, where everything is removed en bloc. En bloc म्हणजे सगळं सोबत काढायचं, सब साथ में निकालने का. The breast, underlying muscles, nodes where breast drains, and everything was removed en bloc as a mass. Next slide, please. But over a period of time, people understood that as we evolved like man over a period of centuries, that you don't need such kind of radical excision. So these radical excisions were associated with a lot of functional and physical deformities, and so came principle of organ preservation. Now, organ preservation means breast conservation surgery, uh, conservative surgeries where principles of plastic surgery were used, and because of that, the outcome was good. So they labeled it as oncoplasty. In some patients, you can put in implants after mastectomy, or we can put some flaps which can be taken off from back, that is LD flap. The radical radiotherapy, which was planned for about 5 weeks, 7 weeks, have given away to just small local therapy for about 15 fractions. Next, chemotherapy, which was more of after surgical procedure, has now evolved to chemotherapy before surgery in a few cases, followed by surgery. So overall, what has happened in, say, last 3 or 4 decades is the radicalness of surgery has given away to organ preservation. More conservative surgeries are being done. The radical radiotherapies has given away to small local radiotherapy or lesser radiotherapy. The chemotherapy is being used nowadays judiciously in some patients, where some chemotherapy is given before surgery so that you do a smaller surgery, directly helping us in preserving the organ. And overall, this leads to better outcome mentally and physically in patients. Next slide. Why there is no difference? Question will come in your mind that whether I do a mastectomy or whether I preserve the breast. What has said that once the breast lump increases more than 2 centimeter, it spreads from one part of the body to other part. So only by doing surgery, you cannot cure patient. You need some kind of systemic therapy, which may be in the form of chemotherapy or local regional treatment like radiation. So what has evolved that even if I do a lesser surgery, patient is going to require systemic treatment. So most important thing is to get rid of whole of gross cancer and let chemotherapy and radiation take care of regional as well as small metastatic disease in the blood. Next slide. Oh, next slide. So what has changed in over a period of 2 decades is that we have been doing a modified radical mastectomy, which was done before by Halsted. So instead of, we are removing breast, we are removing the axillary nodes, but we have stopped removing pectoralis major, minor muscle. We have stopped removing supraclavicular nodes and internal memory nodes, thereby decreasing the functional and physical deformity which was happening before, which with good outcomes, with the similar outcomes as it was before. Next slide. Now, most important advantage of MRM is that radiation therapy may not be needed in most of the cases. But disadvantage is for a young female, loss of breast leading to negative emotional and physical impact. Next slide. Next slide, sir. I'm just showing few pictures of MRM. You can see a lateral medial quadrant lump. This is how the marking shows how a mastectomy is planned. Next slide. And this is a photograph of the axillary nodes which are being removed. You can see this naked axillary vein. These two retractors are retracting the pectoralis major muscles which we have saved. And what you can see is the naked axillary vein with all fibrofatty tissue over chest wall being removed. Next slide. In next picture, you can see whole of the breast is removed, but the pectoralis major muscles remain. And in just below the muscles, you can see the pedicles which supply the latissimus dorsi muscles and the axillary vein. Next slide. So what we save in MRM is pectoralis major and minor muscle, the axillary vein, and nerve to serratus anterior and latissimus dorsi pedicle, that means vein, artery, and nerve. Next slide. So what you see is no physical handicap, but there is an emotional handicap which depends upon different patient. Next slide. But in today's world, what is happening is that we are seeing increase in incidence of younger age group patients. And younger age group patients with breast cancer have aggressive behavior. So cancer in these young patients tend to behave and spread very fast and is notorious to treat. Next slide. If you see over a period of time, 25 years back, whatever you can see in that blue candle was showing you that above the age of 50, you are seeing about 70% of the patient. The number of patient in today's world, which is shown by a red candle, above 50 is just about 50%. So if you see, the ratio was 30% before 50 and 70% after the 50 years of age, 25 years back. The age group has increased, has changed over the percentage has changed to 50-50 now. About 50% of patients we are seeing is less than 50 years of age, and about 50% in above 50 years of age. So more younger patients are getting breast cancers. If you see the graph in detail, we were seeing less than 10% cases up to 40 years of age. And now we are seeing about 20% of the cases less than 40 years of age. Next slide. So what we are seeing, the change is that more patients are seen in more than 50 years of age and less patient in more than 50 years of age. Next slide. Then our data is almost mirroring what we are seeing in cancer registry data. About 45% of our cases are less than 50 years and about 55% cases are more than 50 years. Next slide. So the question which we face in our OPD right now is from these younger patients is, can I still keep my breast? So if the question comes to us is, can I still keep my breast? Next slide. So we have been forced to do laser surgeries or organ preserving surgeries in these kind of patients. So we are moving away from radicality by offering them breast conservation treatment and oncoplasty. Next slide. What do you mean by breast conservation? This is a pictorial demonstration that what we do in breast conservation. In breast conservation, what we do is we remove the breast tumor with a somebody is disturbing. Can you mute, please? Somebody has unmute himself. Yeah, thank you. So in breast conservation, what we do is we remove the lump with a normal concentric margin of a healthy tissue surrounding that. So if this is a breast lump, then you remove an area of tissue which is healthy around that lump in a cosmetically acceptable fashion. That means generally what we do is we take a curvilinear incision in upper quadrant of the breast and radial incision in the lower quadrant of the breast and remove the axillary nodes by a separate incision. So what we are doing is maybe around 30-40% of the breast is out, but 60-70% breast is remaining. And we are still doing an oncologically acceptable job by doing an axillary lymph node dissection. Now, even axillary lymph node dissection, we have decreased in some patient by doing sentinel lymph node biopsy or axillary sampling. Next slide. Slide. So the most important criteria while doing breast conservation is that we should be able to do a local tumor control. That means we should be able to remove it in such a way that we get good margin, number one. And number two, it should leave away a cosmetically acceptable breast. It should not happen कि मैंने एक quadrant निकाल दिया, वो breast टेढ़ा मेढ़ा हो गया, या फिर आधा breast निकाल दिया, आधा breast बचा है, चलो कि भाई ठीक है conservation surgery करें. So you should have a cosmetically acceptable breast on table. Then only you should offer a breast conservation to these patients. And number three, most important, it should be oncologically safe. Most important factor for it to be oncologically safe is it should be the only lump in the breast, number one. Number two, you should be able to remove complete the axillary dissection which you are planning. And number 3, your margin should be adequate. So these 3 criteria should be met if you want to do oncologically safe resection. Next slide. Before doing breast conservation, this is how we connect with our patient. We tell the patient that we are artists, not engineer. We will try to give best possible cosmesis to you, but it doesn't ensure that whatever we are thinking will happen, because patients healing may be different. Patients heal differently, and every patient's healing is different. Next slide. So what are the advantages? Best advantage is that a lady is able to save the breast. At least the breast contour is preserved. All of them should be told that they will require radiotherapy. All patients undergo radiotherapy after doing breast conservation. Generally, what is seen is that since the breast is there, the contour is there, they have less depression and better body image, and they become easily adjustable socially in all Indian attires. All Indian clothes can be worn if you do a breast conservation. Next slide. I'm just showing a couple of pictures that if the patient, I'm pinching a place where the lump is. Next slide. Next slide, sir. And this is how a conservation is done. You remove a part of with a good margin, and what you can see behind is the pectoralis major muscle. So all this is removed in with a margin up to pectoralis major. You remove even pectoralis fascia. Next slide. Now, whatever I am talking is you should not believe, because in today's world, what you will believe will be the evidence-based practice. So I should be able to convince you that MRM is equal to a breast conservation treatment. And I can only convince it if you have trials. Next slide. So as early as 1988, in a small group of patients, Arbuda et al. Published a paper in Journal of Clinical Oncology that in a small subset of patients who present to you in a very early stage, it is safe to do a limited surgery followed by radiation. So it was postulated as early as 1988. Next slide. Next slide, sir. But this postulation was given evidence by 2 people. The first trial was led by Fisher et al. थोड़ा सा ऊपर करेंगे सर. Sir, can you नहीं हाँ थोड़ा सा हाँ बस that it. So नहीं थोड़ा ऊपर सर. नहीं reverse direction. Okay. हाँ. So these 2 are the landmark trials in which patients were followed up for 20 years, where lumpectomy was done followed by radiation, and this was compared with MRM. This was compared with only lumpectomy, and these 2 trials inferred that, which were led by Dr. Bernard Fisher and Dr. Veronesi, and these inferred that MRM versus BCT both were equal. Next slide. This is 20-year follow-up, sir. So there was no their inference was there was no significant difference in overall survival in patients who underwent mastectomy versus who underwent breast conservation treatment in early breast cancer. Most important thing, it's early breast cancer. Next slide. So every good conversation should start with good listening. You should listen to what patient wants, what patient thinks about conservation, what patient thinks about mastectomy. Next slide. You should listen to them first. You should counsel them that in these patients that both mastectomy and conservation is possible, but the final decision, the preference is totally of patient, not even relatives. They may simply opt for mastectomy, even if breast conservation is possible, just for the peace of mind, and I should honor it. we should go ahead with mastectomy and not press her for conservation. Next slide. So this is happening in, say, operable breast cancer. In some patients who present to us little late in stage 2 or stage 3, they still ask a question, is it possible to save my breast even if I have a big tumor? So my answer is yes. Next slide. So in these cases, we can do a preservation by doing a breast conservation in relatively large tumors or locally advanced tumors who have been downstage with neoadjuvant chemotherapy. And after excision of that lump, we can do some cosmetic procedures with the help of plastic surgeons. Next slide. And what are these? Generally, after 3 to 4 cycles of neoadjuvant chemotherapy, there is some clinical response rate. And now, before starting chemotherapy, the 4th point which I have mentioned, always counsel them that if the response is not good, they may still land up in mastectomy rather than conservative surgery. You should be ready for it. Then only you should give them chemotherapy. Next slide. But if they land up in good response, and if you want a good treatment, good outcome cosmetically, you can take latissimus dorsi flap, skin, muscle, soft tissue, and fatty subcutaneous tissue, and locate it in the area where we have done a lumpectomy. Next slide. So this is how a muscle and skin flap is taken, and you take it from back to anterior aspect and fill the gap which we have done in the form of lumpectomy. Next slide. And this is how patients will look after a lumpectomy and reconstruction. If you see the right side of the photograph, you can see that in axilla, you can see that a dimple with some staples. So what we have done is we have done a lumpectomy by doing a curvilinear incision in the upper quadrant. Since it was a bigger lump, we have taken it out. We have filled up with the latissimus dorsi flap. And in the meantime, we have done an axillary dissection by a separate incision. So this is breast conservation treatment with cosmesis. Next slide. And the outcome is excellent. This is our own data which we have presented when I was in TMH in national conferences, that the cosmesis at the end of 2 years is excellent in 72% of the patient. Next slide. So in toto, if you do a treatment in early breast cancer, that is in stage 1, the prognosis is very good. The 10-year survival is more than 90% if the patient completes his or her treatment completely. However, the survival drops down to less than 10% in stage 4 disease. So most important factor which we should tell this to the patient's relatives. Those who are diagnosed, वो तो आ गए, stage 1 में आए, stage 2 में आए, 3 में आए. Our concern is patient's relatives, first degree relatives, real sister, daughters. We should counsel them, we should sensitize them, we should make them aware that prognosis of breast cancer depends upon the diagnosis, the stage at diagnosis. So earlier you diagnose, you are a high risk patient, earlier you diagnose it, better is your chances of surgery. Next slide. Sir, I have some time. Sachin sir?
Yes, go on,
Yes,
sir.
sir. Yes, sir.
Because there are 10 slides which are relevant in breast cancer, but not directly related to breast cancer. Can I continue if I have time? Because we started late.
Yes, sir. Continue, please.
Okay. So the most common vascular complications which we see in, during chemotherapy is extravasation leading to thrombophlebitis, inflamed vein, and sometimes an ulcer is like this, delaying her chemotherapy. Next slide. So what has happened over a period of years? Next slide, sir. We used to put peripheral central venous access lines, which we commonly call as PICC. But PICC was something which was very cumbersome to handle. because it was in hand, so patient has to be very careful. Next slide. It required maintenance by doing regular flushing and keeping the dressing. So there are a lot of problems which led to, which needed, and you needed a lot of understanding how to take care of catheters. But this chemoport had changed the way we are giving chemotherapy now. Most important point which a breast cancer patient is being told nowadays is that the side where you have cancer, you should not do any blood examination, you should not do any pricking, no chemotherapy on that side. So you are left with only one hand with which you need to take chemotherapy. And nowadays, where we are giving targeted treatment for a year, about 51 weeks, you require again and again multiple pricks. So sometimes the patient may land up in these complications. So what we are doing right now is we are putting subcutaneous chemoport. This chemoport is connected with this small white colored catheter, which directly goes and sits in the at the point where the SVC, that is superior vena cava, joins the atrium. So it is centrally delivered, and it is made by by making a small pocket here, and every injections can be given from here without compromising his or her hand. Next slide. There is a pictorial presentation how the chemoport is can be seen under the skin. So it can be put in subclavian vein also, or it can be put in interjugular vein. You make a subcutaneous tunnel here, and you join this this catheter to the port. Next slide. This can be done very safely, and any sister, any paramedical staff, RMO can put in the needle through the skin into the port, and this can be used directly for giving chemotherapy. Next slide. And for removal also, it just requires local anesthesia. Next slide, sir. Just a small word on hereditary cancer. Everybody remembers Angelina Jolie, and because of this Angelina Jolie effect, people understood prophylactic mastectomy in patients who are not having breast cancer as such. Next slide. So what you do for hereditary breast cancer, the most common test which you do is BRCA mutation study. It is called as BRCA mutation study. Now, these are to be done in patients, relatives who are diagnosed very early, that is less than 40 years of age, or multiple people in their family are having breast cancer or ovary cancer, patients who are having bilateral breast cancers. All these people are generally promoted to do a BRCA mutation study in patients' relatives. If it is present, then a prophylactic mastectomy and salpingo-oophorectomy is ideally advised, or they are put on tamoxifen. If BRCA mutation study says that mutation is absent, then it should be treated as if it is in normal population, where clinical breast examination should be started after 40 to 45 years of age group, and mammography should be started yearly after 50 years of age group. So this is something which we are doing, but it is costly. So cannot be advised to everybody. But if somebody who is willing to do it, they should go ahead. Next slide. So in brief, all breast cancer treatment involves 5 steps. Surgery is the most important part because it gets rid of all the visible cancer or palpable cancers which is present. Chemotherapy started as adjuvant and palliative setting, but in last 10 years, we are giving some patients before surgery. Radiotherapy has remained that way, that is adjuvant and palliative. Hormonal treatment in the form of some tablets or some injections are given if they are estrogen receptor, progesterone receptor positive. And targeted treatment if they are HER2 receptor positive. These are the 5 basic steps how you treat a breast cancer. Most important, treatment is straightforward. It is just like mathematics. Important thing is to diagnose it early, to find out these patients in stage 1, especially the younger ones. Next slide. Thank you very much. If there are any questions, I'm so sorry for the delay on my part in joining. because of technical issues. Over to you, Sachin sir.
Thank you very much, sir, for sharing detail about breast cancer. It was indeed a very informative session, and we are grateful to you, sir, for sharing knowledge with us and sparing quality time with us. Thank you so much, sir. The session was very informative and very wonderful session.
Thank you very
Rajesh, sir,
much.
do you want to say?
Thank you
Yes,
very
sir.
much, Amit sir.
Thank you. Thank you.
It was a wonderful and nice presentation as usual, as you used to present earlier also. We had a splendid time at CARE.
Yes.
And a few things I want to ask with regard to prognosis, with the prognosis of ER/PR positive breast cancer and other as compared with other cancer. Which one is relatively?
Sir, I did not include it because I thought people who are joining may not be understanding it. But dictum is you do ER/PR HER2 receptor study. Best prognosis is in patients who are ER positive and HER2 negative, right? Better prognosis in patients who are ER positive and HER2 negative. Worst prognosis if you are triple negative, all receptor negative. So best prognosis is there if the receptor study shows that ER/PR is positive and HER2 is negative. Worst prognosis is when all three are negative. In between, if ER/PR is negative but HER2 is positive, it lands in between.
Another thing is that, is it possible that when we administering a chemotherapy, that met emboli may get lost somewhere in the circulation and cause trouble?
What embolizer?
Any embolies after during chemotherapy, is it possible that some embolism may happen? All
cancers are hypercoagulable states, sir. Any cancer can have thromboembolic events. I mean, nobody can say that chemotherapy triggers thromboembolic phenomena, but all cancers will have hypercoagulable states. So they are a higher risk of having thromboembolic events. However, it is not that postulated unless the sister who is administrating is not taking care of air while pushing some drugs. So air emboli is one possibility, but thromboembolic event numbers, percentage, incidences are more in cancers as compared to normal population.
Because I encountered one such case when I was actually administrating chemotherapy for your patient only. I had one such incidence.
I remember that is what I'm saying, sir.
Then
it is very uncommon, but being a hypercoagulable state, you have to be vigilant. I mean, just because your mind knows, you have been able to treat that patient. But if your mind doesn't know, you'll not be able to treat it because you'll find it difficult to understand why patient has collapsed.
I was placed in a remote place and immediately I got to know, and fortunately I was having low molecular weight heparin. I administered and she was okay after some time.
Right.
So thank you very much, sir, for excellent presentation of the subject. Sachin, I think you should skip my introduction and we will directly switch on to the topic because we are too much late now. And
okay, sir. Okay, sir.
Can I leave, sir?
Yes, sir. You can leave. Sir.
Thank you so much. Thank you.
So on the occasion of this World Cancer Awareness Day, we are conducting this webinar on cancer as the cases of, as I already told by my friend Dr. Amit Jaiswal sir, that the global burden of cancer is growing day by day. It's very important to look for the concept of cancer and description of cancer in Ayurveda and what was the approach of our ancient acharyas to the benign and malignant tumors in Ayurveda. I will share my presentation. I think it's visible to everyone.
Yes, sir, it is visible.
Okay, fine. So what is tumor? It is a mass of tissue formed as a result of abnormal, excessive or inappropriate, uncontrolled growth of the cells, which continues indefinitely. Means there is no the mechanism. It means it supersedes the mechanism to control for it. Basically, there are two types of tumors: benign tumors, which remains localized, forming a single mass and is often symptomless and can be exist completely. Other is the malignant tumor, which is also called as cancer. It invades the surrounding tissues and spread through lymphatics and blood to the other parts of the body, where it gives rise to the secondaries, that is metastasis. Now, let us see how it is given in our Ayurveda. Characteristics of tumor mentioned in Ayurveda, that it is a circular. See, any whether malignant or benign tumor, it starts as a dome shape, only circular. It is a fixed mass, as a mild aching, broad base, slowly growing, and non-supporting big muscular growth. All the characteristics of tumors are mentioned there. In the Vrittam, that is circular; Stiram, fixed; mild aching, that is Mandarujam; broad-based, Mahantam; Analpamulam; and Stira Vruddhi, that is slowly growing; Apakam, that is non-supporting. So this is called as the Arbuda. As per Arbud, that represents the tumor. The types of tumor mentioned in Ayurveda are Vatach, Pittach, Kaphach. These are doshic varieties, and then the Raktach Arbuda, which could be hemangioma or hemangiosarcoma, that is the tumor of the blood vessels. And Mansaj Arbud, this could be even this could be fibroma, or this could be rhabdomyoma, or if it is malignant, then rhabdomyosarcoma or fibromyosarcoma. Medoj Arbuda is lipoma when it's benign, and when it is malignant, it could be liposarcoma. Other types of cancers are mentioned as per their dividation. There is Adi Arbuda, the tumor erupting over the tumor, and Dvi Arbuda, the tumor occurring in pair after one another, is called the Dvi Arbuda. The clinical features of this doshic variety are same like the cysts. In Ayurveda, cyst, Arbud, and Granthi, they are described together. What is the reason for non-suppuration in tumor is this tumor usually does not suppurate due to the predominance of kapha and the meda in it, and this being the oily part, and also due to the stability of doshas owing to cohesive intermixing. The intermixing of the morbid doshas causing tumor is such that it does not cause the means the fibrous material is more there. That's why it doesn't suppurate. The recurrence of why this Arbuda is a malignant one. There are some things which proves the malignant nature of the tumors. As told by Acharya Sushruta, if the leftover portion of excess tumor, regrows very fast, hence it should be cauterized after the excision. This definitely indicates the malignant nature of the tumor because it re-erupts if not completely excised and cauterized. The causes, the commonest causes are the mushti praharadi, the repeated trauma to the muscles, repeated irritations, etc., etc. And these are for the external tumor, and ati mans praya, the excessive intake of meat, that is for the development of internal GI malignancies. So pathogenesis with above causes, there is morbid mutation of muscles and muscular built up organs leading to tumor developments. Is the constant irritation to the muscles and muscle built up the organs leads to the tumor development. Some kind of stimuli is there. Features of muscle tumor, there is the penless tumor, unctus tumor, color resembles like skin, non-suppurating tumor, stony hard tumor, and fixed immovable. These are the typical characteristics of the tumors what we come across. And prognosis of muscle tumor is it is incurable. The etiopathogenesis of this hemangioma that is told in our science is that vitiated doshas vitiates the blood and blood vessels, leading to localized inflammation and congestion of blood in it. The congestion of blood causes upward growing swelling. This growth is covered with the small fleshy projections papillae from where the blood oozes continuously. And the features are the tumor with bleeding, tumor with papillae, fast uncontrolled growth, ashivruddhi, and the resultant is the anemia. That is the constitutional feature. And the other features related to anemia like anorexia, weakness, fatigue, etc. They also can be understood. And the prognosis is very bad. Let us see some other types of tumors in Ayurveda. Gulma is one such condition which resembles the tumor. Gupit anil mulatvat gudamulodayatvat gulmavat va vishalatvat gulma iti abhidhyate. Gudmula iti kandadayaha tesham udadayat gulmavat vanaspathyadi sanhativat the fixed vishalatvat vistirnatvat. And as it is a deep seated one, as it like which the root which is deep seated in the soil and not visible like the tube, not visible, and which is rigidly entangled in itself like tendril, and how broad based it is called as the gulma. The definition of gulma itself is suggestive of a tumor. The Acharya Bhela has told that the intermixing and consolidation of various tissues is called as the gulma. The Acharya Bhela has defined gulma as the intermixing and consolidation of various tissues. Rasadina dhatunam vikarshanam sansargo gulma. This definition of gulma given by Acharya Bhela indicates towards the development of benign or malignant growth in the body. Let's see the Abhyantar gulmas. They are, as I already told, the 5 types of these Vataj, Pittach, Kapaj, these Sanipataj are the doshik varieties, then the Raktajan, Metoj. And the Bahya Gulma, there is one more type mentioned by Vagbhata, that is external Gulma. And sites of this Gulma are hypogastrium and bladder, umbilical region, chest and thoracic cavity, left loin and hypochondrium, and right loin and right hypochondrium, left loin and left hypochondrium. So some of the characteristics mentioned in Ashtang Sangraha of Vataj and Pittach, Pittach and Kafaj Gulma, and their site is Vataj Gulma usually occurs in Basti region, Pittach Gulma in Nabhi region, and Kafaj Gulma in Hruday or Parshva region. And Kafaj Gulma, particularly this Sthir, Guru, Kathin, Avgado, Alparuk, Praya, Vrut Parshvesha. This Sthir, fixed, Guru, heavy, Kathin, hard, Avgad, deep-seated, and Alparuk, mild aching. These all characteristics are suggestive of tumor. So there are some of the synonyms which are used for these different sites gulmas. That is, Gulma in Hruday region is called as Ekrut. The Gulma in Kukshi region is called Ashtila, and the Gulma in Madhya region is called as Pliha. The Gulma in Basti region is called as Chand Vivruddhak, and the Gulma in Nabhi region is called as Granthi. This is given in book called Vaidak Sarvasva. The prodromal features of Gulma mentioned in our science is the looseness in body, diminution of appetite, there is loss of appetite, abdominal bloating, abdominal gurgling, stasis of urine stool, non-passage of flatus, early satiety, anorexia, irritations, which are commonly observed in conditions where you face the tumor. Clinical features: the anorexia, abdominal distension, abdominal gurgling, difficulty in passage of urinary stool, no passage of flatus, irritations. This is commonly encountered in the malignancy of GI tract. and specific features of Kafaj Gulma. Particularly, why I am concentrating Kafaj Gulma, the features of Kafaj Gulma, they are of a malignant tumor. Krutamulam Mahavastu Katinam Stimitam Guru. Jai Kafa Gulmam Gulmum Shar Arishta Agni Karma Bihi. So Acharya said that the Kafaj Gulma appears as if it is covered with wet cloth. Patient has fever with shivering, looseness in body, nausea, cough, loss of taste, heaviness, feeling of cold. And the Gulma characteristics is a fixed one, enlarged, hard lump, and heavy lump. And the treatment approach suggested for it is to treat with the alkalis or cauterize it or excise it. And for that purpose, Acharyas have asked to take the opinion of Dhanvantaris, means the surgeons, and the Sharvid also, those who are expert in applying the alkali therapy to cut. The Sannipadaj Gulma, there is a further advanced stage of Kafaj Gulma, and it is with the severe pain associated with burnings. Mass is stony hard, elevated, rapidly separating, very fatal, leads to fear and depression, which is very common in cancerous condition, loss of appetite, loss of physical strength, and this is incurable one. Another one condition given book called Vaidyak Sarvasva is Yakrut Gulma. And the Yakrut Gulma grows due to Vata, suppurates due to Pitta, and solidifies due to Kapha. The role of all the three doshas are there in development of the Yakrut Gulma. And the characteristics of Yakrut Gulma given are the cachexia, which is very common in cancer stage, vomiting, fatigue, irritations, nausea, dyspnea, syncope, heartburn, thirst, fainting, burning in throat, headache, chest pain, rhinorrhea, pricking pain in chest, heaviness in chest, gurgling in abdomen. And the first time there is evidence of metastasis in Ayurveda. The features of metastasis of this Yakrut Gulma given are yellowish sputum, putrid smell, frequent hemoptysis, bloody diarrhea, fatigue, cachexia, and features of urakshata. When these features occurs in the Yakrut Gulma, it is said that this Yakrut Gulma is metastasized in the lungs. On noticing these features, one should infer that the Yakrut Gulma had invaded the chest. Yakrut Vakshasi Sansrutaha, the terminology is used as. And these are the features of gastroesophageal or liver malignancy, which is metastasized in the lungs. Incurable features of this Yakrut Gulma: breathlessness, thirst, vomiting, confusion, swelling on hands and feet because of this hypoproteinemia and all those things, organic involvements, anorexia, diarrhea. These are classically seen in malignancy. Breathlessness indicates the thoracic invasion. And prognosis is very bad. A lump with established root, Krutamula, lump covered with blood vessels, and Kurmayuva Unnat, lump elevated and irregular like tortoise. This is given in Vyasa Samhita. Kurmunnatam, Shiranadam Tivrati Bahuroginam, Rudnami Pani Pada Shodha, and there is features like weakness, anorexia, nausea, vomiting, restlessness, fever, thirst, drowsiness, rhinorrhea, breathlessness, cough. Ascites is there. When the ascites is there because of the portal hypertension, when there is edema of feet, and gross emaciation. These are suggestive of incurability of the tumor. Another one condition is there that is mentioned in our science is Yakrutudara. Which resembles the hepatocellular carcinoma. Its features, I have highlighted the important ones, and we will see it. Kathino ashtilavat vardamanaha kachap sanstanaha upekshitaha kramena pukshim jatram mrudujara anaha agninash karsha nil haridra rajim udbodhi yakrutapi dakshin parshvastam shwetu janadishi jalodaram strotabhya shonit struti krishna vitakatvam. Now let us see one by one those. In Yakrutudara, the hepatomegaly is Kachap Prishtavat, knobby, hard and irregular, with cachexia, anorexia, difficulty in respiration, to the portal hypertension, and Strotope Shoni indicates the coagulopathy, which occurs in chronic liver diseases. You see, most of the clotting factors, they are produced in liver, and when liver gets itself is compromised, then there is a coagulopathy. Pando is due to the loss of blood loss and due to chronic affection, anemia due to anemia of chronic diseases. Endophageal mild fever are constitutional features. Vritraji, Haritraji Yuktam Mudaram is the caput mediosi formed due to the portal hypertension. There are some other malignancies mentioned in Ayurveda. One such case is Talukachapa, which is again mentioned as kurma. The kurma is tortoise, and whose surface is hard, knobby, and irregular, to indicate that acharyas have used the adjectives of kurma, tortoise. The disease in which there is gradually developing hard, painless growth, like elevated back of tortoise in the palate, is referred as Talukachapa, palatine tumor. And the treatment is, they have told that there is no treatment, it's incurable. They have accepted the fact. And another thing is Talu Arbut, Padmankar Talu Madhe tu Shopam, Vidyat Raktarbudam Poktalingam. The disease in which there is lotus-like growth in the palate, that is referred as Talu Arbut. This is again the palatine malignancy, and it is incurable. Another one is Masa Sanghat, palatine tumor, mentioned. Dushta Masam Shleshma Nirujam Talvantastaha Masa Sangata Mahu. The disease in which there is fleshy, painless growth in the palate is referred as Masa Sangat. It is also incurable one. Another is Balas, in which the aggravated kapha along with vata gives rise to edema in the throat associated with obstructive dyspnea, and which is incurable. So the treatment is incurable, and it is causing obstruction to the flow of air also, and to the flow of to the entry of the food also. This is laryngopharyngeal malignancy. Swaragna, it is laryngeal malignancy. The aggravated kapha gives rise to laryngeal growth associated with change of voice. Because of the invasion of the larynx, there is change of voice, dryness of throat, and dyspnea is there. Treatment, it is incurable, and this change of voice could be because, like Gardavvat, Khara. Another condition of throat malignancy given in Ayurveda is the Shatagni, throat papilloma, in which the aggravated kapha gives rise to laryngeal growth associated with change of voice, dryness of throat, and dyspnea. And you see, everywhere there is the association of kapha is there. The nasal tumor mentioned in Ayurveda, Nasa Strotagata Roga Stinsha Dekasha Kirtitaha Strotapate Yat Vipulam Koshavacha Arbudam Bhavit. The big bag-like growth in nasal cavity is nasal tumor, and there was a way to examine it with the endoscopy, rhinoscopy. Nasa Arbudharnartham Ekam Kulasthidalamatram Mukha Khallam Tishnaushtam. So the endoscopic procedure was used for diagnosis also and for the therapeutic purpose also. Therapeutically, they used to remove the nasal tumor through this rhinoscope. There are 7 types of ear tumors also. This Vataj, Pittaj, Kapach, Medoj, Mankaj, as mentioned earlier. And the earlier said features regarding tumors should be considered with regard to ear tumors also, and accordingly the treatment strategy should be planned. I'm covering it fast as we are lagging far behind the time. Prognosis of tumors, once again we will go through. The tumor from which the blood oozes, which is developed in systems or in vital parts, or which is very much fixed, is incurable and should not be treated. When tumor erupts over the tumor, and when tumor occurs in pairs, Adi and Dvi Arbuda, these stages are also incurable. The Mans Arbuda and Raktajanya Arbuda, which could be, the Mans Arbuda could be the rhabdomyoma or rhabdomyosarcoma, fibroma or fibromyosarcoma. Raktajanya Arbuda is of blood vessels, hemangioma or hemangiosarcoma, if the malignant. So these are incurable. If these are incurable, means the most likely possibility of hemangiosarcoma and the rhabdomyosarcoma. Few words about the treatment of tumors in Ayurveda. There is very interesting approach for the treatment. Acharyas are of the view that apply the paste of sesame, kulti, meat, and curd water on the tumor, and allow the flies to drop eggs on it. And what it will give the development of maggots in it. When maggot eats the tumor significantly, then scrap it little and then cauterize it. Now, after the regression in size, then excise it completely. And again, for the shodhana, cleaning and dressing, Acharya has asked to use the karanja tela, which is mentioned in Vidradi treatment. So the complete mulad unmalan aspect was there, the complete removal of the tumor, because if it is not removed completely, then it will re-erupt. That was the thing. This is of medo-Arbuda, and which could be lipoma or liposarcoma. After fermentation, excise it completely and clean it. Ensure complete hemostasis and then ligate it. For cleaning and dressing, use karanja tela, mentioned for the treatment of abscess to prevent the recurrence of tumor. And it is clearly mentioned in Susha Chikistasana that if the tumor is not completely excised, then it recurs. There is a concept of oncologist was there. You see, you can see, and the Acharya Sushuta had referred the oncologist as Arbudadnya. There were many specialists in those days, Vamanvid, Virichanvid, Arbudadnya, Sharvid, Rasakriyavad. Likewise, there was a specialist oncologist was also, concept of oncologist was also there. So thank you for your patient listening. I will stop here my presentation. And if you have any questions, we can take them right now. And
thank you, sir, for sharing wonderful lecture related to cancer and malignancy in Ayurveda. Thank you so much, sir. If anyone has any question, they can ask to sir. Shall we move ahead, sir?
Yes, I think till they can drop in Dropbox also, but by the time they drop, we can have the reaction from our today's MHS observer, Sampath Bhatani, sir, and from the RVPGA Vice President, Dr. Aishwarya Madam is here.
I would like to request first Dr. Sampath Bhatani, sir, to please place us with your words. He's a MS observer for today's webinar. Bhatani, sir, are you there?
Okay, but I think sir may have left, or our joint treasurer, Dr. Ashwini Madam is there, I think. You can call Ashwini Khandekar Madam to say a few words about the RVPGR organization and the activities that we are carrying here.
Hello.
Welcome, madam.
Hello.
Yes, ma'am. We can hear you, ma'am. Please go ahead, ma'am.
Sir, I just joined.
Yes, ma'am. Please say something about today's webinar.
Sir, I just joined.
Okay.
Please go ahead.
Okay, ma'am. Thank you. Now, I would like to request Dr. Santosh Chauhan, sir, Secretary of Rog Nidan and Vikruti Vignan, PG Association.
Hello.
Hello. Yes, sir.
S-
Welcome,
yeah,
Bhattani, sir.
yeah. Are you getting? Yeah. Okay.
Yes, sir.
I first of all, I congratulate all the members of the Jupiter College, the principal Subhash Wage sir, his team, today's distinguished speaker, Dr. Jaiswal sir, himself, Dr. Subhash Wage sir. He has also uh, given a speech on Arbuda. I think this is a series of webinars have been arranged by the Jupiter College is excellent one. And moreover, the today's speech of the Dr. Amit Jaiswal sir was excellent. He has explained everything about the cancer and specifically the breast cancers to be what to be do and what not to be do. This is good for the students to take notes of this kind of the webinars. It's very important. Secondly, that Subhash Wage himself has explained about the our science, Ayurveda, and the contents of the Arbuda, and its importance to be noted here. I think this kind of the webinars will give the explanatory things to the students and will boost the fraternity, the Ayurveda fraternity. Secondly, I thank to university, the MHS, the Honorable Vice Chancellor, Honorable Pro Vice Chancellor, the Registrar Sir, and the Faculty Dean of Ayurveda. They have given an opportunity to observe this kind of the webinar, and I think it's a good experience to be put here, and all the key notes and the speakers were excellent one, and I think this will help to the students to be in a better way to practice Ayurveda, and the approach of clinical approach will improve them, and definitely this kind of the seminars will help to the continuous medical education also. It will boost the continuous medical education. I think with these remarks, I'll rest my things, and I once again thank you to the organizers and especially Dr. Subhash Wage sir. Thank you very much.
Thank you very much, sir. I think the Secretary of RVPJ, Dr. Santosh Chavan sir, is with us. We would like to have a comment from him.
Yes, sir. Am I audible?
Yes, sir, you are. Welcome, sir.
Yes, sir. Yeah. Today, really, it's pleasure for me on behalf of RVPGA. So our RVPGA has conducting the webinar in association with Jupiter Ayurved College with active initiation of the dynamic principle of Jupiter Ayurved College, respected Dr. Subhash Wage sir. Really, this is the 10th webinar of RVPGA in association with the different organization. Mostly this 10th webinar is in association of Jupiter College with the endorsement of MHS. Really, it's a great pleasure for us. We are conducting such a wonderful, knowledgeable activities for our Ayurveda fraternity with the positive effort of Dr. Subhash Wage sir. Today, just I want to say few words about the today's speaker, Dr. Amit Jaiswal. Intro-like explanation about the breast cancer. And at the same time, Subhash Wage has revealed the references of Ayurveda, which will match with the all aspect of modern science. So really, on behalf of RVPJ as a General Secretary, I am very thankful to the MHS and the today's observer for the today's webinar, respected Sampath Badhane sir. Sir, thank you. Thank you. And again, we will conduct activities in future also, which will contribute a lot for the development update of our Ayurveda knowledge. Thank
Yes,
you.
sir, absolutely, absolutely.
Yeah. Okay. Thank you, sir.
Thank you.
Over to Sachin, sir.
Thank you, Chauhan sir, for your kind words and sparing time with us. Thank you, sir.
Sachin sir, you can proceed for the vote of thanks.
Okay, sir. Now I would like to present vote of thanks. It's a matter of pride for me. I must mention deep sense of gratitude to our guest speaker of today's webinar, Dr. Amit Jaiswal sir, for his lecture on topic trends in management of breast cancer. Thank you, sir. I would like to acknowledge my sincere words to our respected principal who is acting as an energy source. Thank you, sirs, for your lecture and every support you are giving to us. I would also like to thank respected Dr. Sampath Bhatane, sir, for your support and sparing time with us. I'm happy to mention my obligation to Chief Patron Dr. Santosh Chauhan, sir, for his valuable words, and Mrs. Tarini Nikhare, madam. Thank you very much, sir and madam. I also thank Ashwini Khandekar, madam. I also like to thank Dr. Shrikant Hadole, sir, who is the organizing secretary throughout the webinar series. At last, I thank to all faculty members and dear students for patience listening. Thank you, everyone.
Thank you, and I declare this webinar is over, and you can leave now.
Thank you, Swagit sir. Thank you.
Thanking everyone.
Thank you, sir.
Everyone can leave now.